So, good night, everyone. I'm very glad to come to you tonight in maybe a different medium, but always as the organizer for Science Night that we do here in ANZA 48. We are very happy to come to you via YouTube today. We have some people that have been here before, but of course this is 2021, so things are slightly different this year, but still we wanted to come to your places, I guess, in not a creepy way, but kind of introduce to you to what the scientists in Kiel have been doing on COVID-19. So basically, throughout the month of April, every Thursday at 8, we will have a talk that is done by a scientist or a clinician scientist that works here, like in UKSA on the university. And we will try to explain to you a little bit of what we have been doing during this time of pandemic times, and also what we have learned so far about COVID-19. So we welcome all of your questions. So if you have a very pertinent question or something that you just think, this is, again, we hope that this is an open discussion. So just write them in a chat and we will try to address them after the talk. So without further notice, I will introduce our first speaker. Our first speaker of this series is Florian Tran. Florian Tran is a clinician scientist in the UKSA, so also under the umbrella of the Institute for Clinical Molecular Biology, so ICMB, and he's going to kind of give us a little bit of an introduction on the disease that is COVID-19, and also kind of give a little bit of taste of what is to come in the future, so the projects that we will present throughout the month of April. So thank you very much for tuning in, and I will pass now to Florian. Hi, Florian.
Hi, Joanna. Yeah, and thank you very much for this nice introduction. As always, I might introduce myself just a little bit. I'm Florian. I'm working at a university hospital in Kiel. Indeed, I'm not a virologist, to be honest, but I'm doing my specialization in internal medicine or gastroenterology, and basically working now in the ICU, also treating COVID-19 patients. And that's the reason why we get into the interest of also studying this disease. We are basically not, as I said, not virologists. So we have our own view on the disease and how we study it. Yeah. I would like to start with disc pictures. You might think, if we talk about trajectories, and this is what we will do in the next minutes, you might think about flight trajectories of how a rocket launches and or airplane is like landing. So this is kind of what you think about trajectories. We are thinking about trajectories in the disease sense. So either in the sense of like the whole pandemic situation where the disease curve is like going of the whole country, or in our case, we like to study the individual disease trajectory. So whether a patient is doing well or not so well throughout the time. So we are talking about SARS-CoV-2. SARS-CoV-2 is the abbreviation for severe acute respiratory syndrome, coronavirus 2. So basically all of you should know, and I don't need to say too much about what or how this disease is like transmitted. It's kind of like a respiratory disease that's transmitted via aerosols from human to humans, and we are having currently a pandemic situation. We're currently facing a third wave. This is also not new to most of you. So what is our view in the clinic, basically? What do we see in the clinic? So we see patients which are having symptoms, obviously. Those patients who do not have symptoms, of course, do not come to the clinic. And if they come to the doctor, or be it a general practitioner or the emergency room in the clinic, they appear with coughing, they appear with fever, and they actually also appear with shortness of breath, dyspnea. This is a symptom that we call. So at first instance, these patients will receive something like this. It's also very familiar to all of you. It's kind of like a nasal cannula. These people just get oxygen treatment. So this seems to be a very very easy. You give some antibiotics, sometimes if they get a super infection with bacteria and so on. So it's a very, yeah, for most people, you might think it is kind of like a very easy to treat condition. Then we do kind of more investigations on these patients, and this is what I'm showing here. It's a CT scan of a patient which we would say that will be a patient with a moderate disease. And in this CT scan of the chest shows that these are the white blurs in the lung on both sides. These are actually infiltrates, means like you have like infiltration or inflammation in both parts of the lung. And this already looks very creepy and very severe, but this is something where a lot of patients can live with just with a little bit of oxygen supply. But we also see patients which are much worse, which need to be admitted to the ICU because they really can't breathe, even though they have these nasal cannulas. So they need mask or something more severe. They need to be need to get intubated and get mechanical ventilation. And the end stage is something that we would see here. This is kind of like a scary picture, maybe. This is a picture from a press release from the Munich University Hospital. This is showing an ICU patient, and you see a lot of these perfusers, and what you also see is kind of like the red kind of gauges coming out of this patient. It's kind of like blood flowing out of the patient's so-called extracorporeal circulation, and it's basically a heart-lung machine, a machine that is able to replace the heart and also the lung function to re-oxygenize the blood because the own lung is not working anymore. So you see that COVID-19 is kind of like has a very big spectrum from like very mild disease to very severe disease, which eventually lead to death. So we have a huge range of symptoms. So we have people who are completely asymptomatic. We have people who are in critical illness or fatal illness, means like people are dying. We have, depending on the study population, up to 40% asymptomatic patients, asymptomatic persons, means that they do not have any symptoms. They are just positive in their PCR test. So that's the reason why it's very difficult to get the real number, basically, of or a good estimate of the people who are asymptomatic. But from those people who are symptomatic, this is something that you actually can catch very well. We know that the majority of these people have very mild disease, means these people have only fever, they might be coughing, but they do not really have shortness of breath, so not substantially. So they don't even need to get admitted into the hospital. That's very good. They just need to be in quarantine and then need to be treated with like very conventional things like fluid treatment and so on, and these people will do fine. And then we have a proportion of people who are having a more severe disease course, means like they really require oxygen supply because the shortness and breath can't be compensated by just breathing more. They need to be treated on the wards. And then we have a small proportion of patients which are critically sick, and that means that they have respiratory failure, means that even this kind of like normal oxygen supply is not enough. They need to be mechanically ventilated. They have multi-organ failure, septical shocks, and eventually these people are those which are contributing to the overall death rate. Another reason for death, and this is also going hand in hand with what I've been telling you about the critically sick patients. We have seen in an autopsy series that most of the patients which died from or with COVID-19 have a lot of certain kind of like cells which are called megakaryocytes, or it's kind of like one kind of like cell which is producing platelets or thrombocytes. And these kind of cells within our bloodstream are responsible, we think, and this is the result of our study, but this is what also other people suggest. They are responsible for blood clotting. This blood clotting is what we as doctors call thrombosis. And these thrombotic events have been shown to be existent in 95% of the people who died actually from COVID-19. This is very specific, or rather specific for this disease. We did also a comparison with other diseases like influenza, like the common flu. And these people saw that in the flu patients, you do not have this kind of like immunothrombosis in that high proportions. And actually we have like 9-fold increased thrombosis risk in comparison to influenza. And these thrombotic events usually happen in the lung, so people also get deterioration of their shortness in breath. But these thrombotic events can also be in very many other organs, like in the kidney, also in the heart, also explaining heart attacks and in COVID-19 patients. And yeah, basically all kind of like tissue could be involved here. So if you follow a little bit the scientific discussions, you might hear a lot of people saying that there are like a lot of stages of disease. So in the beginning, people get infected. This is kind of like the incubation time. People are having just very mild or subtle symptoms. Then they start to get more and more shortness in breath. They develop fever, etc. This is kind of like some days after they get primarily infected with the virus. And then they are more or less stable at this stage, and then they some of them develop more and more severe disease. This is what you see in this chart, which has been cited a lot of times, which is quite well. If you look at this graph for too long, you might think about that this graph might reflect the usual course of the disease, which is not true, because if this is true, every person will then end up in a hyperinflammatory phase and eventually die. So this is not the usual case. So the real situation is that you have at each stage persons which are reaching the stage, and then with their disease activity eventually slow down or then decreases again. So most of the people actually, as I said before, has an asymptomatic disease course or only subtle symptoms. And this is something that needs to be criticized when showing these graphs. So what is known basically, not only to us, but from what I've said, we have one virus. This is the SARS-CoV-2 virus. We have this infection and this disease that we just call COVID-19 disease. And we have a kind of very heterogeneous disease manifestation. So we have different types of disease, or different kind of disease speed. We have different organ manifestations. And we have, of course, different disease severities. And basically, it's very hard to say from the beginning if you would like to do kind of a prediction of a person who just get primarily infected with the virus, whether this person is getting a mild disease or a very severe disease, and how long the severe disease will be, and also which organ might be affected. So to get a little bit of explanations for these different disease courses, people will try to find risk factors, and people also want to know what severe COVID-19 actually means. So what is the definition of severity of disease? So what is known now about potential risk factors of the disease, and this is common knowledge. We know that the male gender, that means that male persons are more at risk in developing a more severe disease course. We have persons at higher age, which are, of course, also very much at risk. So with increasing age, you have like a higher mortality and morbidity risk. Smoking, this is also very, very obvious. People who are long-term smokers with over 30 pack years have a more than twofold risk to develop a severe disease course leading to hospitalization. And which is also not too surprising is the socioeconomical status. So it's people having low socioeconomical status have rather low access to healthcare system, to sanitary facilities, and this is also kind of a risk factor. But more scientifically, let's say it like this, we people also from Kiel, this is the Andre Franke group, they have they were trying to find genetic factors which are predetermining the risk in getting a more severe course versus a not so severe course. And they found in a large cohort from Spain and Italy that different areas of the genome are responsible for or like more are explaining the risk for getting this disease severity. And one of these risk loci is shown here. That's the ABO system, and their key finding was actually that the people who are carrying the blood or having the blood group A are more at risk in developing a severe disease course, and they actually have a twofold risk over people who have the blood group O. So you can say blood group A is like having more at risk, and blood group 0 is like less in risk in developing a disease course that's leading to hospitalization. We also know that other diseases are kind of interfering with COVID-19. Means like if you have pre-existing diseases like diabetes, obesity, cancer, and other organ diseases, that this is rather unfavorable for the individual patient. So this is also something logical. And this is actually also mirrored by the current strategy of vaccinating people in this country. So this is what I'm showing you now is the risk category 2. So people who are over 70 years old and plus, people who are having some of those shown comorbidities. So what is a severe COVID-19 disease trajectory here, and what are the molecular characteristics? The WHO had very early already provided a kind of like disease severity scale, which tries to capture the disease severity of COVID-19 basically. So it's kind of a scale from 0 to 8. I'm trying to get through the scale. So 0 is kind of people who are not infected, means like people who did not really get in contact with the virus, and 8 is death, and there are a lot of stages in between, obviously. So people who are not really having symptoms are scored 1 or 2. People who have symptoms which need to go to the doctor or need to go to the hospital are already scored 3. So if you are in need of oxygen, and this is like for most of the patient the case, you are scored 4. And then there are like different other stages of these kind of like oxygen supply. So I showed you the picture of the lady with the nasal cannula that was scored 4. Then you have this kind of like high pressure, non-invasive ventilation with the mask. This is what is shown here. Then you have people who get mechanical ventilation by an intubation, and this is scored 6, and scored 7 is what I showed you, this extracorporeal membrane oxygenation, which is kind of like the last level, or other kind of like organ replacement therapies, for example, renal replacement therapies if the kidneys are completely crushed within the multi-organ failure. And yeah, as I mentioned, scored 8 is the death. So it's kind of, it already looks like you have like a kind of a stratification of disease, but if you look more in detail into this, we have no involvement of other signs or signs of inflammation, or like the burden of inflammation, which is also part of the disease, very much indeed, is not part of the score. So the score only takes into account the form of ventilation that the patients need. So this is like the first drawback of this score. The second point is that this score does not respect whether someone is like on his way to get a more severe disease, or his disease severity is like decreasing. So this is what I'm trying to show here in this graph, that if you look at this disease trajectory and just draw a line here, you have like 2 points of the disease, two different time points of the disease, and the lab values might be the same, and also the ventilation state might be the same, but biologically this is like completely different, because this is point 1 is like a kind of a situation where you don't know whether the patient's still surviving, and point 2 is like, okay, you know the patient's like getting better, and he might get out of he might be extubated and so on. So that was the situation that we were facing earlier last year. So we were approached by a lot of people during that time, means like in March and April, whether we can also contribute to science on COVID-19. So we were actually asking ourselves whether we can contribute to the molecular understanding of COVID-19 using our expertise and resources. I'm saying this because we are, as I said, we are not virologists at all. We are working rather in the field of gastroenterology, and so our working group that Joanna is, so Joanna and me are the same working group, and we are working together basically on chronic inflammatory bowel disease, also a severe disease. And what we are actually doing is we want to understand the also different disease courses under a specific therapy. And what we do is to understand the molecular behavior of this disease in many regards. So we are checking, for example, the genome, the epigenome, the microbiome, and all this information together is giving us kind of like the real picture of disease, or more or less real picture of disease.
Through time. Through time.
Through time, that's true. Yeah, and our idea was to basically do the very same in COVID-19, to transfer our expertise. So the situation in March, just to sum it up again, we were facing the first lockdown in Schleswig-Holstein that started in 14th March 2020. That was the first wave here, and our project was indeed embedded within one kind of like national initiative, which is called the Deutsche COVID-Omics Initiative, means the German National Initiative for Omics Research in COVID-19. Joanna and Neha will tell more about it in the next talks. And our job in Kiel was to basically managing the study, which is trying to find out these molecular and cellular features which are defining severe COVID-19 disease trajectories over time. Yeah. So this is our trial. This is the COVID-Omics trial. We called it like this. It's a multi-center trial, and Kiel was coordinating this actually. And as I said, the idea was to do a longitudinal sampling for molecular analysis. I will not go into detail this time. We try to understand the patient themselves as well by doing a very dense clinical phenotyping. Means like we get a lot of clinical lab values. We checked the patients for a lot of clinical signs, and including real-time vital signs. What we also did was to create kind of like an own disease score, because as I introduced before, we were not completely happy with just using the WHO introduced disease severity score, which did not include the inflammation part. So we used the WHO score still as kind of a backbone. We added an own scoring system of inflammatory markers, including CRP, for example, or IL-6 or ferritin. These are kind of like inflammatory markers. And we also try to respect the direction of the disease progression. And this is what we have defined as so-called pseudotimes. Means it is not kind of like a real phase, but a kind of a pseudo phase, because every patient has kind of like a variable time in each disease phase. So this is what we call pseudotime here. And this is what you see here. We color-coded it for the different pseudotimes. And we included this pseudotime 1, which is here in pink, which is the so-called incremental phase, because we think that the increase or increment of a disease burden is somewhat biologically completely different from the other disease phases. And with this, I would already like to wrap up, and so I hope that I was able to explain a little bit about the rationale of why we are studying this disease and why we were focusing on disease trajectories themselves. And for the molecular analysis part, I would like to refer to Joanna and Neha, who will be talking in the next weeks. Yeah, that's it. Thank you very much.
Thank you, Florian. Yeah, so I just wanted to say a shout out. If you have any questions, please write them in the chat. Also, I think I speak from Florian when we say that from our project, one special message we like to send is that we're very sorry for the families that suffer throughout this disease and all participated in the study. This was very difficult times, especially during April and June. So thank you for participating in our study and for helping us understand a little bit more of this disease. We hope that our contribution was also something that they can have in the back of their heads when they think about these times. So I think I have a question for you, Florian, a really simple one.
Okay, that's
so
good.
You talk about inflammation a lot. What is inflammation?
This is not an easy question. It's actually a very difficult one.
It's a very difficult, but you talk so much about it. So what is it in very simple terms?
It's kind of like a natural reaction towards either something which is infectious, yeah, or something also not infectious. But this is kind of like an immune system which is reacting to something. Basically. So this is what I would say, which is inflammation. From a clinical perspective, if you would ask a doctor, it's kind of like something with, so it's associated with fever, with like reddening, with like kind of a swollen tissue. This is something that you can see in the lung, obviously. Yeah, but you will have kind of like organ affections due to the inflammation and increased temperature. This is something that we would see.
Fever.
Fever.
Yeah.
Yeah. Yeah, and of course this has something to do with an immune reaction, means like immune system, and you have like different immune cells which are contributing to this inflammation. This is very complicated to explain here, but this is basically just kind of like an activation of the immune system.
Okay. So another question. You talk about thrombotic events, like clots.
Yeah.
And I've been turning on the news and I hear about thrombotic events and clots caused by the vaccine. Is there anything to this?
So this is quite a different story, these kind of like thrombotic events after this certain kind of vaccine. Than what you see in COVID-19. COVID-19 is what we see is kind of like a cell-mediated kind of like a clotting, because these kind of cells, it means the megakaryocytes and the blood platelets, are kind of like hyperactive and they have kind of like weird properties. This is what we actually found out. And this is then attributing to COVID-19 related thrombosis. The thrombotic events after the AstraZeneca vaccine is due to kind of like different kind of antibody reactions. And this is kind of similar to what you see in so-called HIT. It is kind of like the heparin-induced thrombopenia. It's kind of like also an autoimmune reaction, but it's from a pathophysiology completely different to what you see in COVID-19.
Okay. So I should not be scared of taking the vaccine.
You should not.
That's good.
Well, yeah, it's kind of like, again, so this is like a complete different story than getting COVID-19 itself, because, I mean, you need to weigh the risk of course, side effects of vaccine and the side effects or main effects of the disease.
Okay.
This is a quite different story here.
So what can I do on my everyday life to help you that works in the ICU make your job easy and preventing more people to get infected by this disease?
Well, it's actually very easy. Of course, people need to get vaccinated. This is also kind of like different story. But of course, you need to try to get the or stick to the measures and rules that are out there, like wearing a mask, etc. Sticking to hygiene measures. I think this. Keeping distance, this is kind of like the most important thing. And this is also very indebatable.
Okay. Any questions from you, audience? Now is the time. Okay. I can have more questions. I can be here all night. But yeah, I think we can wrap this up. Mm-hmm. Or would you like to say something about... No, you're good.
Yeah, so I'm basically good. I'm very thankful for being here.
That's nice. Yeah, it's a little bit different from the last time you were here, talking about fecal transplants, which was indeed a very funny talk.
Well, I think that's not less interesting.
Definitely not. I've seen things that night that I cannot unseen. Thank you. Okay. But yeah, hopefully you'll be working on fecal transplants soon instead of working on COVID.
Well, so the government asked me not to do fecal transplant currently in the COVID-19 pandemic.
Yeah.
So it's actually forbidden because they say, and I think that's a good point, that COVID-19, the virus particles themselves are also replicated within the gut, right? And the people, so you never know whether your donor is SARS-CoV-2 positive. So the stool might also be contaminated with this, and that's.
So they don't test the people when they go into the hospital?
Sure.
For like a normal procedure?
Sure, but
there's incubation.
Yeah, for the FMT, you also need to get very fresh stool. So, okay. Also, different topic.
Oh Lord, help me. Okay. Yeah, so I think that is it. Stop it, I don't want to think about it anymore. I'd like to thank you for joining us again, and hopefully you will not have a lot of work in the future because this is going to end up, and then we can start and have, again, Science Night here in Anza all together. So for you people at home, thank you so much for joining in tonight. Next week, we're going to have a fantastic speaker that is going to talk about the molecular signatures of disease. That speaker is me, indeed. And then after that, we're going to have a very interesting presentation by Tim Holstein. He's going to talk about diabetes and kind of there's very poorly understood connections with diabetes. And after that, we will have Neha Mishra, which is talking about the future projects that will happen here in Kiel and here in our institutions, and how we kind of go forward from what we have learned so far. So thank you very much, and have a nice night. See you next week.